Hi, my name is Dr. Avnish Deobhakta, and I'm an assistant professor at the Mount Sinai School of Medicine, New York Eye and Ear Infirmary. And I specifically am a specialist in retinal diseases, and I do both vitreoretinal surgery as well as treat retinal diseases in the clinic. Well, so it's a really great question to ask about the types of diabetic retinopathy. The types of retinopathy are divided into two parts when it pertains to diabetes. The first is called non-proliferative diabetic retinopathy, and that's sort of like the earlier form. And that one is one in which patients often don't even know that they have the retinopathy, and it can manifest as having little blood spots like on the retina. We call them microaneurysms. And you can see areas of change with sort of fluid deposition and that sort of thing. The more severe form is more advanced. We call it proliferative diabetic retinopathy. And the reason why we call it that is because these patients with this particular form have a lot of bleeding often, and that bleeding can be very clinical. It'll block their vision and that sort of thing. So it's very important whenever you have diabetic retinopathy to be able to distinguish between the stages. So the symptoms of diabetic retinopathy are very important to keep in mind. The two ways that diabetes can affect the retina is first, you can actually have a blurring of the center part of your vision. And that doesn't really happen overnight, and it can happen pretty much in both eyes. And so you may be unable to read fine print, sort of read see the TV screen, look at the computer, or even look at your phone, which most of us have in our hands all day. But the other way that diabetic retinopathy can present is a little bit more scary. You can have big floaters, which can be just overt bleeding into the eye itself, and then that can actually obscure the center part of your vision, or it can obscure lots of parts of your vision. And so, and that can happen in either eye, or it can happen in both, but typically it's in one eye or the other. So in particular, those are the ways that diabetic retinopathy will present and why people sort of show to my clinic. But I will stress that in many cases, patients don't even know that they have diabetic retinopathy. And so it doesn't actually have a clinical kind of thing, kind of symptom. And so it's important always to be seen. So the great question to ask is, how do you reduce symptoms? And I always say the number one way to sort of reduce diabetic retinopathy and sort of the risk of developing diabetic retinopathy is very easy. It's just go see your eye doctor. So I often give talks, and one of the talks I give, there's a statistic that I like to quote, which says that if you merely see your eye doctor, if you have diabetes, your risk of developing really severe diabetic retinopathy and other forms of eye-related disease decreases by 98%. So really, that's the most important thing that you can do. So I would always say, see your eye doctor. And then the second thing that you can do is to basically, and you all know this, to reduce to control your blood sugar. And so I always say, it's not very easy to always control it perfectly, but if you can get anything, controlling your blood sugar is really important because it can reduce the rates of both diabetic retinopathy, which is the eye disease, but also all the other forms of issues that you have throughout your body, such as the kidney issues or the brain issues or the heart issues, the neuropathy issues where it's hard to feel things. Those things get reduced as well. So seeing your eye doctor and then also controlling your blood sugar. That's a great question. I would say that there's two forms, as we've classically divided diabetes into two forms. The first form is type 1 diabetes, the second form is type 2, as most people know. Oftentimes, type 1 diabetes can be very genetically linked, and type 2 diabetes can also be genetically linked, albeit less so. But we all know that there's also environmental forms or reasons for why people have diabetes. And so I always say, diabetic retinopathy in particular sort of follows that. And so you have, some genetic reasons for it. Your family members may have diabetes in their history and diabetic retinopathy in their history. But in reality, it's really a lot of it is environmental. So sort of controlling your food intake, not smoking, trying your best to exercise. So those things affect it as well. So I would say that it's a very important question, and I think it's a group of patients that we really need to pay attention to, and I often do in my clinic. But pregnancy can really affect the progression of diabetic retinopathy. So either you can start off with having diabetes, and then it can get worse, and progress while you're pregnant, or if you don't have diabetes, you can develop gestational diabetes. And in both of those cases, diabetes, the diabetic retinopathy can get worse in line with the diabetes that you have. And so what I often say is it's very, very important to get seen again. I think that's the hardest part, is to get seen by your retina specialist or even your ophthalmologist, because there's so many other appointments that these patients are going to. But it's very, very important to go and get seen, because there are things that we can do to either slow it or to even sometimes basically stop the retinopathy in its tracks before it can actually cause problems. Now, to the question of whether or not after delivery does this resolve itself, the answer is, of course, it does mitigate it. You can get your diabetic numbers can get much better after delivery, but the issue, of course, is that it often doesn't always go away. And sometimes, even if the diabetes itself resolves, it doesn't mean that the retinopathy is resolved on its own. So it's still very important if you have a diagnosis of gestational diabetes, or if you have a worsening of your underlying diabetes once you become pregnant, to be seen by your retina specialist or your ophthalmologist even after you've delivered. So that is an excellent question, and the easy answer is yes. So I will say that diabetic retinopathy is a treatable disease. Now, it's not a curable disease, just like diabetes. So until we find a cure for underlying diabetes, we won't have really, I believe, a cure for diabetic retinopathy. However, that does not mean that there's no hope. That does not mean that you're going to be going blind if you have diabetic retinopathy. And I treat a lot of patients with diabetic disease in their eye. My joke is often that I'm a diabetic doctor who happens to be a specialist in retina, because there are so many patients with this disease that we actually do slow down, or we do actually control their diabetic retinopathy. And so it can be, and we have a variety of treatments that allow for that. So diabetic retinopathy is treated, as I alluded to in the earlier segment, with a few ways. And the three major ways that we do it are with, one is called a intravitreal injection. And so the word intravitreal injection is sort of complicated and also sounds scary. There's an injection, and what does that mean? So it does mean that we do put medicine inside of the eye itself, and that sounds very, very scary. But I will point out, and I always do this to patients, point this out to patients who are receiving these treatments, that we do not give these injections sort of without anesthesia. So when you usually have injections in your arms, when they have a blood draw, or even diabetics are very well known for having blood, knowing how to do finger sticks, those, we don't use anesthesia for that. So you actually feel the pain prick when it goes in. That is not the case for these injections. But yes, the injections do go in the eye. And why do they go in the eye? Because we're delivering a very, very specialized medication to the back of the eye where the retina sits. And what it does is it really treats all of those areas of bleeding. It treats a lot of the areas of swelling and fluid deposition that occur, and even areas where, certain areas of the retina that are not receiving blood sometimes, it can help with that too. And these injections are very, very precise in terms of the medication. And there are a variety of classes of medications that we use now that have been sort of created in the last 10 years. So it's a very, very modern form of treatment. And so that's basically axis number one, where we try to really control the diabetic retinopathy using this type of treatment. Now, the other form is a little bit older, but it's equally as effective, especially when someone's having profound vision loss from diabetes, where there's a lot of bleeding, and we're getting there a little bit later, but we're still gonna push back the retinopathy. And in that case, what we use is something called laser. Now, we've heard of lasers before, I'm sure, in sort of movies and science fiction, but these lasers, they're not invasive, which is an interesting thought when you think of a laser treatment, because it's a light beam that's being focused on the retina, but nothing's actually going inside, nothing physical. But what does the laser do? It actually treats the retina permanently. So it really, really treats like the surrounding tissues, and it establishes a way for the retina to kind of reduce all of the bleeding on its own in a way. And this treatment is very, very effective for profound kind of situations where the patient is really losing vision, and there's a lot of bleeding, and it can really reverse some of that. And it's a wonderful treatment option. We do that quite a bit as well in tandem with the injections. And of course, the final thing that we do for very severe cases, and I happen to be a retinal surgeon, is we do surgery. And mind you, surgery is not, the worst thing in the world. Oftentimes, it's one of the most effective treatments we can do. We have a lot of advances in surgery at the New York Eye and Ear Infirmary of Mount Sinai. We have multiple different, we're state-of-the-art machines. We're involved in academic research, and so we do a lot of surgery. So it doesn't mean that just because you need surgery, there's something really bad going on, but it is part of our armamentarium for treating this disease. So it's a good question. So my answer, whenever someone asks me about the varying treatment methodologies, sort of luckily it doesn't. So it doesn't. Our treatments do not vary by age or necessarily gender. Of course, if we're talking about a very, very young patient, we may only be able to do any sort of procedure in the operating room. But I would say the real cohort, the group that we want to be very vigilant about, are patients who are pregnant, as we talked about earlier, because there are forms of the medicine that we give inside of the eye that cannot be, it's hard to use when a patient is pregnant because it could affect the baby. So we're kind of limited sometimes in our ability to treat pregnant women, which is why it's very important to be very cognizant of that. But in general, patients sort of, no matter what the age, they are able to get most of the treatments that we have. And I would argue that maybe, someone who's very old, it's hard to do surgery for them. But for the injections in the clinic, the laser treatments, these are things that are open to everybody. And in my opinion, these are wonder treatments because they really do help. So the other eye conditions that are related to diabetic retinopathy include cataract, which is when the lens of the eye is actually a little hazy. So the eye is basically a camera. I like to explain it that way. And when the lens of the eye is hazy, then the light can't get through. And instead of calling it just the lens, we call that hazy lens. We call that a cataract. So when the lens of the eye is hazy, we call it a cataract, and that sometimes has to be treated with cataract surgery. But one of the things I often tell patients is our cataract surgeons are some of the best in the world, in my opinion. And what the surgery they do is the best surgery that we have in all of humanity, because the risk is low, albeit not zero, and the benefit is so high. I mean, we do this surgery more than any other surgery on planet Earth, cataract surgery. So it is something we are very good at as humans doing. So if we develop a cataract because we have diabetes in the eye, it's not something to really stress about. However, you can also develop something called glaucoma, and glaucoma is more of a progressive disease, and it really needs to be managed by our wonderful glaucoma specialists that we also have at Mount Sinai and New York Eye and Ear Infirmary. And what they do is they basically maintain the pressure of the eye, because the pressure can go up in the eye if you have diabetes and diabetic retinopathy. And in particular, there's one very, very kind of bad form of glaucoma, in which it's like the advanced form of diabetic retinopathy, where blood vessels grow aberrantly and they can bleed. Well, instead of it happening in the retina, it can actually happen up in the front of the eye, where the drain of the eye is. And so you end up with a very kind of strong form or a severe form of glaucoma called neovascular glaucoma. And so you can have that associated with it, and then you have to treat that as well. So it's very important, again, to see your eye doctor, because you have to be cognizant that you can have these different conditions affect the eye. What is DME? So DME stands for diabetic macular edema. And now those are, medical terms, but it's very simple. So the retina, which is the thing that we've been focusing on in this talk, the retina is like the camera film of the eye. And so just like we have the lens, the camera film of the eye is very important. But the center part of it is where all the light focuses, where all of your vision is. And instead of calling it the center, we call it the macula. So that's just our word for it. So it's the macula, and the word edema just means swelling. So basically what we're saying is swelling of the center of the retina due to diabetes. And it's something that can affect your central vision, as I spoke about earlier, and that's something that we like to treat. So DME, or again, diabetic macular edema, or again, swelling of the center part of the retina, is diagnosed using a very precise tool that we have in our clinic called an optical coherence tomograph or tomographer. And all that is just light beams that are used to image the retina and allow us to get a sense of the thickness of the retina. So the retina is very, very thin, but then we want to look in the thickness of it, because if we look in the thickness of it, then we can see if it's really thick or if it's normal size. And if it's really thick, our technology is such and so precise that we can even see little fluid bubbles develop in the retina, and that tells us that you indeed do have diabetic macular edema. And then once we define that and we say, okay, you're diagnosed with this particular disease, you'll probably will be measuring your visual acuity, and we'll be looking at whether or not it's affecting you functionally. And the idea is, can we treat that with the medications that I was talking about earlier, or with the laser that I was talking about earlier? But we would make that determination with these imaging techniques and with our exam. So one of the wonderful aspects about being at the New York Eye and Ear Infirmary of Mount Sinai, and certainly having access to clinicians that are also involved in academia, is that when it comes to being part of clinical trials, when it comes to being part of novel treatments that are coming on the horizon, we're very involved in that. And I can say that in particular for diabetic retinopathy, there are many different types of treatments that are coming out. One of the treatments that I just heard about was one where there's an oral treatment where hopefully maybe they could give you a pill, and maybe that could make some of this fluid go away. Now that's not ready for prime time, but they're definitely studying it. Of course, anytime you take a pill, there could be some side effects, so they're trying to make sure that they minimize those, or if they can avoid those, that would be the best. The second is, when we do these injections into the eye, one of the issues is that these injections have to be done very repetitively. They don't just, there's no cure, right? As I said earlier, so we try to give injections sort of in a monthly basis on some patients, and in other patients we can extend that interval a bit, but most of the time it's actually pretty frequent. And so some of these technologies have now developed a surgical implant where someone could maybe surgically put a port inside of the eye, which we do for other diseases, and then you can fill that port with this medicine, which can then deliver some of this medicine over a period of time, therefore not necessitating these injections that we need constantly. And then there are other medications that have just come out where the actual medicine that we inject can actually last longer. So right now, we may inject you once a month, or we may even get you to the best point where it's once every 2 months or once every 3 months where you have to come in and get your intravitreal injection. But these medicines, these newer ones, maybe they're going to extend that interval to 4 months or 5 months or 6 months. And so that is actually a very great advance for our field. And certainly, I think patients would love, if they're having treatment, to have these types of advances that they can take advantage of. And Mount Sinai is a great place for that. And then I talk about the laser. In the laser space, there's different forms of laser, different types of lasers, and that has really advanced in the last 25 years. And then in surgery, we are very cutting edge. We now have access to heads-up displays where we're using sort of 3D views. We're using real-time imaging technology. We're using ridiculously small gauge surgery, which means that the actual wounds that we make are self-sealing. And so these are all these different things that we've done. But like I always like to stress, at the end of the day, merely seeing your eye doctor is basically the best technological advance that you could make in some sense, because just getting access to this stuff from us and the information and the diagnosis is very helpful for any patient with diabetes.